Good evening, everyone. This is Elise Kramer, your Public Education Chair from the Scleral Lens Education Society. It's an honor to be here tonight and to have you all here. I'm excited to have the last webinar of the year, and we've had a great webinar series, but this is definitely one of my favorites. So just some housekeeping slides for the best audio experience. Close all unnecessary windows on your computer. Ask questions using the on-screen control panel. And then the control panel can also be minimized if you like. If the webinar screen is lost, click on the blue flower icon found on your taskbar. I am accompanied tonight by Dr. Roxana Hamadi. She is the Public Education Chair elect, and she will be in charge of the questions at the end of the webinar. So please ask questions. We will definitely get to them at the end. So it is my honor to introduce our three amazing speakers tonight. Dr. Muriel Walker is a clinician scientist who specializes in anterior segment inflammatory diseases and managing specialty contact lenses. After graduating from the New England College of Optometry with an OD/MS degree in 2013, she completed a one-year cornea and contact lens residency at Pacific University in Portland, Oregon. In 2014, she joined the clinical faculty at the University of Houston College of Optometry and subsequently entered the PhD program in physiologic optics. She completed her PhD in the spring of 2021, congratulations, with a dissertation entitled The Impact of a Scleral Lens on the Eye. In September 2021, Dr. Walker began a position as a tenure-track assistant professor at UHCO, where she focuses on research of the ocular surface and tear film. Her clinical and research interests overlap and include scleral lenses, keratoconus, and other ocular surface diseases, as well as myopia management for children. She is a fellow of the American Academy of Optometry, a fellow and the current president of the Scleral Lens Education Society, as well as an advisory board member of the Gas Permeable Lens Institute. Dr. Stephen Vincent is an associate professor in the School of Optometry and Vision Science at the Queensland University of Technology in Brisbane, Australia. He is a fellow of the American Academy of Optometry, the Australian College of Optometry, the British Contact Lens Association, the Scleral Lens Education Society, and the Higher Education Academy. Dr. Vincent's research interests include the visual optics of contact lenses and refractive error development. He has published over 115 scientific papers on these topics. Dr. Muriel Schornack received her OD from the Illinois College of Optometry in 1998 and completed a residency in primary eye care at the Illinois Eye Institute in 1999. Upon completion of her residency, she joined the staff of the Mayo Clinic in Rochester, where she is currently a consultant in the Department of Ophthalmology and an associate professor in the Mayo Clinic College of Medicine. She is a founding member of the Scleral Lens Education Society and the SCOPE Scleral Lenses in Current Ophthalmic Practice Evaluation research team and remains active in scleral lens related research activity. It is an honor to have all three of you tonight. Thank you so much for being here, for educating us. I'm excited to learn from you, and let's go.
Thank you so much. And I think right off the bat, I'll say it's an honor to be speaking and presenting for the second year with Steve and Muriel. And I think I need to adjust my bio because there's no way that mine should take longer than theirs. So it's really an honor to be on with them. I'm just saying hello quickly. I'm going to pass it over to Steve in a moment. But I did want to just introduce our next month's event, because usually we talk about the next month's webinar before we introduce the speakers. But this year we have the webinar, or the webinar quote is going to be at the GSLS International Forum for Scleral Lens Research live meeting. So this is the annual research meeting that the SLS sponsors and is a part of the Global Specialty Lens Symposium. So join us. I'll remind you at the end, here's a look at the agenda. So what we're in store for, it's again, a research meeting all of us on here will be there, except for Steve, because he is probably going to be stuck in Australia. But with that, I just want to let you know to sign up for that. You can find the link on our website. You probably have gotten an email. You can email me if you need more info. But I want to get started, so I'm going to pass the baton over to Dr. Vincent. He's going to talk to us about conjunctiva and sclera.
Thanks, Maria. So yeah, I've been tasked with conjunctiva and sclera update, looking at research that's sort of come out over the last 12 months or so. Thank you. So this was a paper that we all co-authored. This was published in late 2020, and this paper is a really deep dive into the anatomy of the conjunctiva and the sclera, things that we need to think about in terms of scleral lens fitting in relation to the landing zone, and how it interacts with the conjunctiva, and the potential effect of scleral lenses on these tissues. So compression underneath the landing zone, conjunctival prolapse, and potentially changes in intraocular pressure, which Muriel is going to go into detail with later. In addition to that review paper, there were a number of papers published earlier this year by the BCLA. So this was in contact lens anterior eye, called the CLEAR reports. So this was really a very large project where contact lens researchers and clinicians gathered together, evaluated the literature, and sort of tried to develop evidence-based guidelines based on solid research. So these are all available online, free to download. Papers that will be of particular interest to this audience, scleral lens fitters, are the Anatomy and Physiology report, which is very detailed overview of all the tissues involved in contact lens wear or affected by contact lens wear, the scleral lens paper, obviously, and the medical use of contact lenses. So would encourage you to go and check those out if you haven't already. Okay, so just going back to conjunctiva and sclera, let's have a look at starting with conjunctival shape and tissue elevation and things we need to think about when fitting scleral. So really in the last sort of 3 or 4 years, our knowledge about the shape, quantifying the shape and the change from the cornea to the conjunctiva, the elevation profile of the conjunctiva has increased dramatically. And in panel B there, you can see the blue area is the cornea, the green area is the conjunctival radius of curvature, and the red patch is an elevation or a pinguecula right next to the limbus. And in panel C, that's just a normal elevation profile of a healthy eye across sort of 15 to 18 millimeters. And a lot of what the studies have shown us is that, the further we go from the cornea beyond the limbus, the more irregular or less spherical the conjunctival elevation profile becomes. And a very interesting study published a few years ago now, on the next slide, was by Greg Denia's group, looking at what is the typical conjunctival elevation profile in patients. And really what this study showed us was that very few patients have a spherical conjunctiva. So the further out we go from the cornea, fitting these lenses, the more we need to think about perhaps fitting a customized or a non-spherical landing zone. So in this particular study, it found that, the majority of patients did not have a spherical conjunctival elevation profile. Patients had, these dips and bumps, and really we need to be thinking sort of toric, quadrant specific, totally customized landing zone perhaps for our patients. So options that we have available. On the next slide, we have obviously our standard spherical lenses. We can modify the width of the landing zone, modify the overall diameter, or we can go to a toric, quadrant specific, a topography-based landing zone if you have access to a corneoscleral profiler, or in cases of, very highly irregular corneal conjunctival shapes, we can take an impression. And this particular case report here is just a nice example of a patient who had a penetrating eye injury, highly irregular corneal surface, but also a very irregular scleral shape as well. And this patient was managed to restore their vision with a quadrant-specific landing zone design. So that's the kind of situations where we're thinking about using these lenses with highly modified landing zones. Alrighty. Other things we need to consider in the landing zone. So little anatomical obstacles or anomalies. These are a couple of nice case reports published in Eye and Contact Lens, where practitioners have sort of navigated these obstacles by either creating a vault, so in that first case report there, elevating the lens in a very specific region of the landing zone to vault over a conjunctival cyst, and in the bottom two cases there, creating a notch in the landing zone to maneuver around a bleb following trabeculectomy for glaucoma and a pinguecula. And on the next slide, we've just got a little video. One of these case reports shows how you can, attempt to manufacture a notch or create a notch in office. Obviously, you can liaise with your lab to do this as well. This case sort of talks about how you can do this in office just with a Dremel, a grinding stone, grinding tool, and a polishing rag. But it does note that if you don't get the notch size correct, maybe you've got inadequate seal, you're going to allow debris from the tear film into the post-lens tear layer, maybe air bubbles as well. Of course, you could break a lens in office, potentially damage any coatings on the lens. And if you don't smooth out the notch perfectly, maybe you could exacerbate the anatomical obstacle that you're trying to avoid. So they're things just to keep in mind, but it is a very nice case report about how to manage those tricky conjunctival lesions in office. Okay, this was a study, a nice multi-center review by Muriel. So really, she should be talking about this, but it's come under my jurisdiction of conjunctiva and sclera. So this is a really nice review of a number of cases managed with impression-based lenses. So these were primarily patients who had been unsuccessful. 70% of patients who'd been unsuccessful with a standard scleral lens fit. 40% of patients who'd had prior anterior segment surgery, so corneal graft, glaucoma surgery. So these are highly irregular surfaces. And really this just gives us some good information about the number of visits required, the number of lenses required in these cases. So patients are out of lenses for a period of time to allow the ocular surface to settle before taking an impression. 1.3 impressions on average required per eye, 2 lenses ordered per eye, and 4 visits required to get good impressions and finalize the lens fit. And very pleasing in this study is that these patients had an improvement in their VA from their habitual correction, so spectacles, corneal GP, regular scleral lens, from 2050 to 2030, which is fantastic. Okay, what other options do we have for quantifying the conjunctiva, the sclera, the anterior ocular surface? So obviously OCT, which is primarily in clinical practice in Australia used for quantifying how much corneal clearance you have, are you vaulting over the limbus, and other devices for mapping the cornea and the sclera are really corneal scleral topographers. So the SMAP, Pentacam with the corneal scleral profile module, and the eye surface profiler. So I just want to take you through some work we've done in our laboratory looking at how you can potentially improve the repeatability of some of these devices. So in this particular study, we looked at improving repeatability for the eye surface profiler. And in this study, the authors attached a video camera to allow you to get a bit more depth perception of where you are positioning the instrument from the eye, and also installed a blue LED series of lights to allow us to visualize the fluorescein pattern on eye, because typically you don't see that when you're taking these measurements, although fluorescein is in the tear film. So on the next slide, you'll see what it looks like. Here we have on the left, the original viewing system. So this is what it typically looks like with the ESP taking a measurement. And with our modified viewing system, you can actually see how well the fluorescein is spreading, so you can ask the patient to blink again, and you get some depth perception of how far you're positioned from the eye. And really what this study found was that if you had these hardware changes, you could improve the repeatability or reduce the standard deviation, the noise in these measurements, by about 40% on the cornea and on the sclera, which is kind of important, particularly in a research laboratory where we're trying to quantify very small changes in measurements over time in the same eye. So that's the setup we're sort of using in our laboratory. So a number of groups have looked at the repeatability of this instrument, and typically out in the sclera at a 15 or 16 millimeter chord, the repeatability is about plus or minus 30 microns. And that's also what we found in our study. It was highly repeatable centrally in the cornea, and then about plus or minus 20 microns out where most sort of scleral lenses land. Okay, other things we've looked at in our laboratory, what are other things we need to think about? Does accommodation or when the patient converges affect our scleral measurements? And what this study looked at was had the patients accommodate by 5 diopters and converge by 9 degrees independently and also together. And what this study found was, if we just bring up these the data here, yeah, if you when a patient accommodates, it doesn't change our scleral measurements too much, but when a patient converges, we actually get a marked flattening or artificial flattening and forward movement of the sclera, which sort of throws out our sagittal height measurements, and this is just sort of due to contraction of the muscle. This is mainly happening in the nasal sclera, so just something to be aware of in clinical practice, particularly important in research projects as well, that patients are really perfectly aligned with the instrument. Otherwise, we're getting significant changes of 20 or more microns. Okay. Other research that's been going on in terms of corneal scleral profiling, a lot of studies starting to look at, are these instruments comparable or interchangeable? And most of these studies have looked at eye surface profiler and the pentacam module. So a couple of studies here. The first study I think we'll look at, this one was published in the Optometry and Vision Science Scleral Lens feature issue. It looked at normal subjects only, so non-keratoconus or grafts. These are just normal eyes at a 15 millimeter chord almost. And what this study found was that the pentacam overestimates the sagittal height compared to the ESP by about 300 microns and underestimates the scleral toricity. So that was one group in Europe doing that study. And then the next slide, this was another study published in Eye and Contact Lens just a few months ago, where normal subjects used again as well. It looked at the same sort of measurements at a similar chord length, and it found the same thing, that the pentacam substantially overestimates the sagittal height at a 13 and 15 millimeter chord by about 400 or 500 microns. So this is quite a substantial difference. So these studies, they don't really tell us which instrument is the most reliable compared to a reference sphere. It just tells us that these instruments are not interchangeable. So they do give quite different results in terms of estimating that sagittal height or sagittal depth at a specified chord length. So I'm just going to finish off with heading back to the anatomy, some work we've been doing on identification of the limbus and changes that occur in the conjunctival tissue right next to the limbus. So some work we've been doing with engineers in our lab is really, training using artificial intelligence, machine learning to train software to be able to identify anatomical landmarks that we're interested in. So we take an OCT image or a pentacam image, and we have someone manually mark all these layers that we're interested in, so cornea, conjunctiva, sclera, crystalline lens in this case, and then we train the software algorithm to identify these landmarks, and from that we can take out metrics that we're interested in. And this is particularly useful for contact lens fitting with sclerals, sort of inspired by Jan Bergmanson's work, where he talks a lot about the limbus and how it's a transition zone, and it's not a clear, obvious point always where the limbus truly is. So in this particular study, we had some expert anatomists or optometrists identify where they thought the limbus was, and then we trained the software to try and identify that location as well. And what we found was you could train software to do this. So this would be useful for contact lens fitting, particularly with sclerals. You could take a measurement with your instrument in office, and it could reliably detect where it thought the limbus was, and then you can design your lens based on modifying things to make sure you're clearing the limbus, you're comfortable where you're landing beyond the limbus, or if you want to put a fenestration in the lens, you could potentially put that right at the limbus. And just the last study that we recently published earlier this year from our lab, this was looking at conjunctival prolapse. So no doubt you've seen this in clinical practice where conjunctival tissue is being drawn up onto the cornea or into the post-lens tear layer. And there's lots of theories around what's going on here, you know, suction forces, too much compression, too much clearance. So we sort of did a study looking at this only along the horizontal meridian. We were interested to know, you know, what are the factors that might be causing this conjunctival prolapse. So we used OCT to quantify the amount of prolapse or elevation of the tissue that was there. We manipulated the fit of the lens, so we increased the amount of limbal clearance and central clearance. We had the patients wear the lens for a short period of time, and we were looking at, you know, is it how much clearance you have, is it how much compression you get or settling of the lens, or how much tissue compression underneath the landing zone that was contributing to the incidence or the magnitude of the conjunctival prolapse. So this was a repeated measures experiment, and what we found was it was quite common. So we defined prolapse as sort of any elevation in conjunctival tissue. There didn't seem to be an effect of fluid reservoir thickness, so the amount of clearance you had, but again, this was only along the horizontal meridian. We found for when patients were fitted with not much clearance, so only about 100 microns of clearance, the eyes with conjunctival prolapse had greater clearance. They sunk back more into the eye, but there was no association with how much tissue compression there was right under the heel of the lens. So it was an interesting study, but certainly future work needs to look at the vertical meridian, which is where we certainly see more of this in clinical practice. And I think that's the end of my conjunctival scleral slides. Just want to thank everyone in the lab who contributed to the studies that I just spoke about. I'm going to hand over to Maria, who's going to take you back right to the front of the eye.
Thank you. Very interesting as always. This is always kind of a teaser for me to hear about what Steve and his lab have been up to for the year. So yeah, moving on to the second paper that the three of us published together was the eyelids and the tear fluid. And of course, my research with the tears has made me most interested in kind of this aspect. But I'll talk a little bit about the eyelids. There really hasn't been any or much research specifically looking at the eyelids, but there has been certainly a lot of publications and a lot of case reports on ocular surface disease and patients who have have eyelids that are diseased and would potentially interact with scleral lenses, such as keratinization, tylosis, etc. And then we'll switch gears. I'll talk about the fluid reservoir for most of my little session here and talk about some of the work we're doing in our lab. And then kind of talk about some of the papers that have been published in the past couple of years that I think give us a glimpse into where some of the fluid reservoir clinical care and research is headed. So just briefly talking about the eyelids, GPC is probably, and really this is conjunctival, but we kind of considered it as being part of that eyelid structure. There's never been a specific incidence reported of GPC with scleral lenses, but interestingly, the work that Muriel and her colleagues have done with SCOPE did a survey, and she actually published it in a proceedings from one of the previous IFSLRs. And they looked at over 700 practitioners, found that it was the most commonly reported conjunctival complication, but still affected less than 1% of wearers. So GPC is not something that we see rampantly with scleral lens wear. The research on it is relatively limited. If you look over to these images on the right, these are images that are published in the review paper and are from Muriel, and it's basically showing a couple of different conditions, right? So OCP and GVHD are two conditions that Muriel certainly sees, probably most of them, of the three of us certainly, but certainly with these patients with their eyelids, there's a lot of case reports showing that symblepharon growth is more restricted when you have a scleral lens, and that they can, in most cases, be used to reduce some of the negative interactions between that conjunctival surface and severe ocular surface disease and the cornea. So that's it for eyelids, and this is kind of our speed run of the most interesting research we think that's currently going on. And so, of course, for me, that's going to be fluid reservoir. And most of us know, of course, if you look on the right here, that we have this deep fluid reservoir in between the scleral lens and the surface of the cornea. And so there's a lot in this layer, and you know, not going to talk about oxygen per se here, but you also have obviously gases diffusing through that layer. So in the actual normal tear film, we know there's hundreds of proteins. Got just this schematic here on this epithelial layer, glycocalyx interacting with the mucoaqueous and the lipid layers. And so when we put the scleral lens on here, it obviously is trapping that. And there's lots that people have looked at. So these are, again, from our review paper, looking at, these are the different studies that have looked at tear exchange. And tear exchange was one of those things that was really looked at a lot, maybe 2 to 10 years ago. It doesn't seem to be something that a whole lot of groups are continuously looking at. I think that it's evolving, and I think if we go full circle, and when I talk about how I think things will be headed in the future, and in terms of using lenses therapeutically to deliver medications and things, I think that tear exchange becomes relevant again. All of these tear exchange studies had variable findings. They were mostly very well done using flow photometry, typically to look at fluorescein moving in and out of a scleral lens. The consensus is that most individuals have less exchange than with other. And I'm going to play these 3 videos simultaneously because this is just, of course, my clinical perspective. And these are 3 of my patients who are all doing very well. And obviously you can tell we've put fluorescein on the eye with the lens on, and you can see it allows you to visualize whether or not tears are going under that lens and whether or not there's some exchange. You can see those 2 top videos, certainly the right side more than the left, are getting quite a good amount of pumping of that fluorescent tears into the fluid reservoir, and on the bottom maybe less tear exchange. So just a little clinical perspective to kind of confirm what those studies have shown. It's going to be quite variable in well-fitting lenses. If we look at the tear properties, so tear properties being things like ocular surface temperature, things like osmolarity, T-bud. You can see there's been 4, I think might be another one out now, but 4 studies that have looked at the actual tear properties. So really found no change in ocular surface temperature. One study found increased, one study found decreased osmolarity, so not really much consensus there. And the tear film surface shows changes, and they actually talk about maybe it's this bogging. So again, I'll show my clinical images of these sort of non-specific changes to that tear film surface, but no staining. And in fact, there have been a couple of studies on here that found a decrease in actual punctate staining, which kind of goes hand in hand with what we see in a lot of the clinical studies on ocular surface disease and management of persistent epithelial defects. So looking at the actual tear study, so looking at what's in the tear, so looking at cytokines, looking at how the optical density changes. Again, this year, Muriel's got another paper here on the optical density, and pretty obviously you find that the optical density of this fluid reservoir increases with time. And then there's been a couple of studies starting to look at midday fogging and what's actually in there. And I'm going to share some of the data that we have on that now. And one of the studies here, this was the Postakov study down in 2019, I'll note, did find slightly more, but not significantly more. They found neutrophils, which is, of course, a type of leukocyte and type of white blood cell. And they found them more in midday fogging. So this midday fogging remains, I say, this cumbersome phenomenon. And so we're continuously trying to learn about it. Part in my lab, as one of our main goals is learning more about that. And of course, if you've seen me talk about it before, you know that what we do is we collect the fluid reservoir right out as we take the lens off patients, you can usually collect 20 to 100 microliters. And so we can do a lot of different testing with it. So this is something that's actually quite new. This is just some pilot work that we've been working on these past couple of months, collecting the fluid reservoir and just staining it with different stains and treating it with some different treatments. But this is the most simple representation. And you can see on the right, we have taken a midday fog sample. On the left, we've taken a sample from a patient who wasn't experiencing midday fogging. And we did what's called an H&E stain, which essentially is going to stain any cells. So it's going to stain the cytoplasm pink and the nuclei purple. So certainly we see a lot of cells in this midday fogging. And what we're actually looking at here, you can see the little red asterisks that come up in these little clusters, these little tiny little cells here. You can see those are PMNs, polymorphonuclear cells, so neutrophils. And then if you see here, where the green little asterisks came up, those larger kind of flatter cells are epithelial cells. So we have confirmed with our preliminary data, but working through the study, that we do see these neutrophils like the Postakov study did. We're also seeing a lot of epithelial cells in these samples. But that story is to be continued as we gather more data there. One study that we did finish this year and talked about a little bit at Academy, but will be published and is currently getting reviewed. So looking at lipids and proteins in midday fogging. And so we did look at 13 subjects. Basically, we collected the fluid reservoir. We used the OCT to actually quantify the midday fogging. And then I'll briefly mention the cell culture. That's what I talked about at Academy, if anybody was able to see that. But those both should be coming out hopefully soon. So very quick, just kind of run through on the main results that we found. Looking at the samples, we did detect over 1,000 lipids. So again, we're collecting that fluid reservoir from the scleral lens, looking at it. This was with mass spec. The major lipids, and the story is a little bit more complicated than that, but the major lipids that we detected were a lipid called wax esters, and it was actually made up about 11% of the lipids detected in the midday fogging group, and only about 4% of those that were detected in the group that did not experience midday fogging. Lots of different species of wax esters were detected, and we also actually found that cholesterol esters. And if you look at this graph here, you can see that with increasing midday fogging, and this did reach significance, the relative abundance of the wax esters also increased. And looking just quickly at what a wax ester is and what a cholesterol ester is, and these are actually the chemical formulas for, or the chemical structures for a few of the main lipids that were found. And so they all have ester groups, and they also have these fatty acids. And so if you look here, the commonality is really these hydrophobic fatty acids. And so what we've pieced together from this is that these wax esters and cholesterol esters, which make up about 60 to 80% of meibum naturally, so they're very nonpolar, which means they're very hydrophobic, so they do not mix well with aqueous or water-based solutions. So the fluid reservoirs here showed a lot of these lipids, but much more in the midday fogging samples. We think maybe this could be related to meibomian gland dysfunction, because some of many patients with MGD have increased wax ester and cholesterol esters in the same ratios that we saw, but we'll have some follow-up work to look more into that. And just very quickly, we had done some cell culture experiments. So just a little bit of a teaser. We basically seed epithelial cells into a small plate, human corneal epithelial cells. We incubate them with the fluid reservoir samples. We look at after we treat them, we remove the fluid reservoir and we stain the epithelial cells. And the staining essentially tracks the movement of transcription factors, which, long story short, is indicative of protein synthesis and ultimately inflammation. And so again, taking the fluid reservoir out, culturing it with the cells, and here are the cells with the staining. And so you don't have to understand what this means. I'll zoom it in a little bit. Basically, what we're looking at is that yellow circle is the cell boundary. And you can see in this particular example, the green is most concentrated in that white circle, which is the nuclear boundary. And so if you look at the subjects who have more of this, what we call translocation, more of that green that's concentrated in the center of the cell, like in the left and the right-hand side of the image, that indicates more translocation. And on the left side, you can see less translocation. So again, even if you don't understand those images, that means that there's more translocation. So when we see more translocation in these experiments, it means that the inflammatory response is increasing. And again, we see this positive trend where increasing scores of midday fogging, so severities of midday fogging, we see more of the translocation, so indicating more inflammation. So with this research that we've been doing, really we found that probably cells, neutrophils, epithelial cells, and these lipids may be a little bit different with different patients, but all of them could potentially be increased in midday fogging, and that this is triggering inflammatory pathway in corneal epithelial cells. We don't know what this means for the patient, but learning more about it and how we can manipulate really this fluid reservoir. And with that, I'm just going to spend a couple of minutes talking about what I think is really interesting, which is some of the work that's been done and where I think this fluid reservoir research really means something and it is going anywhere, because really it's all about what are we going to do about it if we learn that X, Y, and Z is in there. Well, I think the ability to manipulate it and learn how this fluid reservoir interacts with the cornea is really interesting. And so this was a paper published a couple of years ago that evaluated how much antibiotic was able to penetrate into the cornea and into the aqueous humor and even into the vitreous. So they used an animal model. They filled the fluid reservoir with fortified antibiotics and basically measured the concentration. And so you can see here in the control, you of course have no movement of this antibiotic, and when you have the medication in the actual fluid reservoir, you increase the corneal penetration as well as aqueous and vitreal penetration. And so putting something in that therapeutic system and being able to treat really corneal conditions, I think is huge. And we've seen this in a couple of studies that have been published so far. One was published in 2019. This is a Boston site looking at using basically anti-VEGF of Avastin, and they would put the Avastin drops into the PROS lenses. This was a PROS study, and these were patients with neovascularization, and you can see the A is the before use of the Avastin in the fluid reservoir, and B is after. So they used it for several months, had several underlying conditions, no adverse events, and so it was really a promising use for a medication in that fluid reservoir. I'll also mention this is a new, so most of us know that Oxavate has recently come on the market, and this is the preservative-free nerve growth factor, or NGF. And so there's been studies on and looking at this and finding that it helps with neurotrophic keratitis. It's customarily dosed 2 hours, every 2 hours for 8 weeks. So I know I've heard of anecdotal reports of putting this in the fluid reservoir. I think it will be interesting to see where that sort of research goes. So with that, I will punt it over to our last speaker, Dr. Muriel Schornack, who will finish up talking about IOP.
Hi there, everyone. My portion of the presentation is going to be considerably more clinical than what either Steve or Maria presented. Two reasons for that. Number one, I am primarily a clinician. I don't have a lab, I don't work in a lab, I just work in clinic. And number two, there hasn't really been a lot of new research published on intraocular pressure and scleral lenses during the past year. So I thought I'd simply try to make some sense out of currently published research, and that is what we attempted to do with the paper that was just published. So maintenance of a physiologically healthy intraocular pressure really does involve complex interactions between a number of cell types, receptors within the eye. Scleral lens wear could conceivably disrupt some of these autoregulatory processes. So we took a look at the processes and then postulated how scleral lenses may affect them, and then closed out by making some guesses as, or taking a look at the literature that's been published. So just a real quick anatomical review here, very high level. If you want more detail, it's in the paper. Aqueous is certainly produced through active transport by the anterior portion of the ciliary body. It flows into the posterior chamber, or the area between the anterior surface of the crystalline lens, posterior surface of the iris, through the pupil, and then into the anterior chamber, where it circulates by convection current, providing nutritional molecules for the cornea to support metabolic health, and also clearing off waste products. And then most aqueous exits the globe through the trabecular meshwork or Schlemm's canal, but there is also diffusion through the uveoscleral pathway as aqueous exits the eye. So this is just a really nice graphic. Thanks to Jan Bergmanson for allowing me to use this. Notice that the trabecular meshwork becomes increasingly dense as it approaches Schlemm's canal. So in the outermost, or I'm sorry, the innermost portion of the corneoscleral meshwork, waste products are actually phagocytized and digested. As you move towards Schlemm's canal, the meshwork becomes denser, and finally you reach the juxtacanalicular tissue, which does regulate the flow of aqueous into Schlemm's canal. So just a really quick review. Aqueous will flow through the trabecular meshwork into Schlemm's canal, where it leaves Schlemm's canal going into collector channels, drains into aqueous veins, into scleral veins, and then into general circulation. And there are compensatory mechanisms to either elevate or lower intraocular pressure at every step along the way here. So it is a very complex system. Delicate balance, as I mentioned earlier, in addition to all of the autoregulatory mechanisms, intrinsic and extrinsic factors can affect intraocular pressure, including diurnal variation, respiration, and heart rate. If you've had a large bolus of a fluid intake, that can increase your intraocular pressure. Exercise, head position, or body position can affect IOP. Position of gaze, if you're looking in an extreme position of gaze, IOP can be elevated. And manipulation of the globe can either drain IOP from the eye or elevate IOP, depending upon the form of manipulation. So lots of factors go into this. So when we place a scleral lens on the eye, we obviously manipulate the eye. So what might happen? These are images from the paper that we just published. This is, I don't know whose eye this is, but it was from Maria's institution. You can see anterior chamber IOL in A without a scleral lens in place, and then in B, scleral lens is in place. And note that Schlemm's canal looks just slightly deformed in B compared to A. Also notice that there is some compression of ciliary body tissue, which could potentially impede upflow of aqueous from the eye. So you'll see here a picture of an eye in nasal gaze, which causes the lens to shift temporally and causes a little bit of blanching of conjunctival vasculature that may extend down into the episclera. If that is present, you may see an elevation in intraocular pressure that is magnified with scleral lens wear in extreme positions of gaze. You might even notice it in primary gaze if the lens edge fits relatively tightly. Now, the question of long-term impact of conjunctival vasculature with scleral lens wear has yet to be answered, but the eyeball below is actually a photo of the same eye but here the lens is actually off, and you can see a junction between where the lens usually rests and conjunctival tissue that's not usually affected. So it's possible that scleral lens wear can cause some long-term effects in conjunctival structure and vasculature, but that has not yet been studied. So some preliminary observations. McMoney's first published a review in 2016 postulating that scleral lens wear could cause elevation in intraocular pressure either through subatmospheric pressure buildup behind the lens during wear or by obstruction of drainage channels for aqueous. We do have some predicate information on scleral lens coil, or I'm sorry, on scleral search coils that were sometimes placed on the eye to record eye movements. And several of those studies did show an elevation of intraocular pressure with the presence of a search coil on the eye. Finally, a recent study actually utilized the potentially compressive effect of scleral lenses on episcleral vasculature to treat hypotony following trabeculectomy with mitomycin C. So it certainly is possible to elevate intraocular pressure with scleral lens wear if you want to do so. So what are some of the challenges we face in research? Well, number one, you can't get to the cornea when you're wearing a scleral lens, and you really can't measure intraocular pressure through a scleral lens. There are a number of studies that take a look at the pressure in the eye with soft lens wear or measurement of pressure with soft lens wear, and you can really use standard corneal measurements for that, but you can't with sclerals. The potential impact of application and removal, again, that involves manipulation of the globe, so could potentially raise or lower eye pressure. Scleral lens wear can change corneal thickness or corneal rigidity, so we need to take that into account when we're measuring intraocular pressure through the cornea. And then there is certainly some variability in lens application techniques. If you take a look at these two photographs, this is the same lens on the same eye, on the same day, about 15 minutes apart. The image on the left is a picture of the lens as applied by the patient, and apparently there was a fair amount of posteriorly directed force during that application process. The image on the right is the eye applied by me very gently to the surface of the eye. So you can get some variability depending upon the force used to put the lens on the eye. So what kind of instruments have been used in studies so far? Well, Schiatt's tonometry has actually been validated for peripheral use, but it has to be held vertically, so the patient must be in a supine or lying down position. Pneumotonometry, which is the photograph of the eye with a little probe on it, has also been used for both corneal and peripheral measurements, and a patient can sit upright during measurement. The tonopen immediately below the pneumotonometer has been used, but not validated for the peripheral measurement of IOP. Eye care, limited utility unless you use a fenestrated lens, which has been done. And finally, transpalpebral tonometry has been suggested as a method of measuring intraocular pressure during scleral lens wear. So the study designs that we've had so far, you can either measure the lens right before, or measure IOP right before you put the lens on, and then after you take the lens off. Upside there, you can use any instrument you want. Downside is that you really are not figuring out what's going on to the intraocular pressure lens during scleral lens wear. You're simply getting an idea of what happens with the application and removal process. You can measure intraocular pressure during lens wear if you use an instrument that does not require access to the cornea. You're actually measuring the variable of interest there, but it's possible that the instruments are not accurate when you measure peripherally. And finally, you can measure intraocular pressure while you're wearing a modified lens. Advantage there, you can use an instrument that requires access to the cornea, but lens modifications may alter the normal interaction between the lens and the eye. So quick summary of results on pre and post lens wear studies. So two of the studies reported a change in intraocular pressure pre and post scleral lens wear. Now notice that the Walker study is in both columns. That's because a change was noted when Maria used rebound tonometry, but same lenses, same eyes, same days. No change was noted with transpalpebral tonometry. So variable results even within one study. Taking a look at IOP assessment during scleral lens wear, notice that most of these studies utilized transpalpebral tonometry. If they reported a change, the one outlier was Steve's study that took a look at rebound tonometry through a fenestrated lens. Of interest, the FOAT study also used both transpalpebral and pneumotonometry, did not notice a difference with pneumotonometry, and ANOVA analysis suggested that the difference was due to the instrument used. So questions that we need to ask, is IOP affected by the instrument used to measure it? And given the fact that 2 studies using the same eyes on the same day in the same patient came up with different results between 2 instruments, I think we can say that the instrument used can certainly lead to some variability in that value. What's the ideal amount of time to wait to measure IOP after lens application or removal? What amount of IOP change should be considered clinically significant? If we find a statistically significant 1 millimeter increase in intraocular pressure, does that really matter clinically? And how do we account for the impact of potential corneal changes during scleral lens wear on IOP? We really need to take a look at some long-term studies. And the first 2 studies here did in fact take a look at corneal changes following scleral lens wear in actual patients, found no difference in cornea compensated IOP after at least 1 year of follow-up. Shanazi did a retrospective review and found no significant change in IOP. Our own Dr. Kramer did find a non-significant increase in IOP in 17 patients or 31 eyes. So one other thing to consider here, who's actually wearing scleral lenses and are their corneas normal? Well, we've got patients with keratoconus. Their corneas aren't normal. We've had patients who've undergone refractive surgery or cross-linking or even dry eye disease. All of these things can alter corneal biomechanical processes. So is IOP truly the best way to measure potential for glaucoma in these patients? Let's think about what we really want to know. I don't care about IOP for its own sake. What I really want to know is, are we causing an increased risk for glaucoma? What is glaucoma? It's optic nerve disease. So we got to use the right tool for the job. And Maria and Dan Smaha actually did take a look at optic nerve structure. And of interest, 2 studies performed in a similar way came up with different conclusions. Maria found no significant difference in the change in minimum rim width between study and control eyes over 6 hours of wear, while Samaha actually did find a significantly more change in minimum rim width during a study visit compared to measurements obtained during a control visit. So questions, how much variability is there in minimum rim width from one day to another? And if minimum rim width varies significantly, does that increase a patient's risk for glaucoma? So now I have to talk a little bit about one of my favorite Disney movies, Up. If anyone's ever seen that movie, the dogs actually kill it. Every time they see a squirrel, they get distracted. And I wonder if the optometric community has done just a little bit of that with intraocular pressure and scleral lenses. Have we become a little bit distracted there? Are we actually missing something that's more important? One of my earliest mentors suggested that when I thought I had a good research question, I should always ask why at least a few times before proceeding. Basically, what I want to know is how worried should I be about elevated intraocular pressure and scleral lens wear? Well, my answer is based on what I've seen. I'm aware but not worried. So what do I really want to know? We ask the question, what happens to IOP during scleral lens wear? Why do I want to know it? Well, I want to know if scleral lens wear increases the risk for glaucoma, and I want to know that because I want to know how to counsel my patients. So what are some clinical considerations? You always have to balance risk versus benefit. If I have a patient who is a glaucoma suspect, but is going to undergo a permanent total tarsorrhaphy if I don't get a lens to fit, I'm going to put them in a lens anyway. On the other hand, if a patient with a strong family history of glaucoma and elevated intraocular pressure is interested in wearing scleral lenses for correction of uncomplicated refractive error, I may encourage that patient to consider another option. Clinically, I think we can rest assured in the fact that there are multiple tributaries through which aqueous can leave the eye. So if we happen to obstruct one pathway with a scleral lens, there are other ways that aqueous can leave, and in a healthy eye, autoregulation is likely going to be able to maintain a homeostatic balance. One more final clinical consideration. Always remember that you're treating eye disease. You're not simply putting a piece of plastic onto an eyeball. A patient is more than a pair of eyeballs, and an eyeball is more than the cornea. So we need to be aware of the whole thing. Some of my patients think that I am providing their entire eye care when in fact I'm just looking at the lens. So I've learned that I need to be very intentional about asking patients if they're receiving general eye care elsewhere. If they're not, I'm going to make sure that I do a very complete ocular evaluation. I'm checking risk factors for glaucoma through both patient history as well as clinical examination. And if I see any risk factors, I will certainly proceed to testing. So as of right now, there are no reports of scleral lens-induced glaucoma. Of course, if we don't look for it, we're not going to see it. So I think surveillance is certainly a good idea for your scleral lens patients, but I would not avoid fitting a scleral lens on a patient who may need one due to a concern for glaucoma. Thank you.
Thank you to all of our speakers for this awesome lecture. Honestly, it was such a great review of all the scleral lens research from this past year. I'm going to ask for all of our speakers to come back on, and we're going to go through a few questions. And for our participants, there will be a survey at the very end of the webinar. Someone did ask, this webinar is being recorded. It will be available on the SLS website, I believe in the next few days to the next week. So Dr. Walker, I know you did discuss using Oxavate in the bowl of the scleral lens, and I want to ask all the panelists, have any of you guys had any experience with that?
I can respond. Muriel, you've probably, have you guys done it have you guys been doing that at Mayo?
You know, we haven't prescribed very much Oxavate, actually.
Yeah.
It's relatively expensive, and insurance is always, of course, an issue. I have not tried to put it in the bowl of a scleral lens, although that's certainly an interesting concept.
Yeah, and I'll say, you know, I always, you know, want to be careful on this. So I do have a couple of patients who, you know, I'll say specifically off-label. You know, they're patients who I manage their scleral lenses, and they have a corneal specialist who's managing their NK. And it's very early. I really couldn't make any statement about whether or not it works or doesn't. I think it's just an interesting area to think about. I think if it's indicated, you know, barring what Muriel mentioned, there's some logistical. We've been pretty lucky. You know, I've heard that optometrists have trouble getting the Oxavate approved, but the ophthalmologists that we have at Baylor College of Medicine have been pretty successful. I think they've got a system that they've got going there, because so I'm not typically prescribing it myself. So maybe that's where it makes it a little bit easier, but we have a couple of patients that I'm co-managing. But I think it'll, you know, I'm big supporter of the research, and we'll see where that goes. So, you know, we can't say anything for sure yet, but I think that we'll see a lot more research in that area using the device to treat.
Perhaps an interesting aspect here is that Oxavate is so new that we really don't have a good idea of what it does when you use it on label. So trying to determine if you get increased benefit if you use it off label is going to require controlling for variables that we haven't even defined yet. So I don't think we can answer the question, and I don't think we're going to be able to answer the question if as to whether or not you should place this in the bowl of the lens for some time. I think it's going to be tough to do that research.
No, great answers. As far as IOP, I know we were talking about there's some research coming out about that. Has anyone looked at if fenestrations help with the IOP under the scleral lens?
Well, Steve should probably talk about that. He did a study with a big, huge fenestration, but the lens wasn't very wearable, if I'm not mistaken there.
That's right. So well, that study was just a way to access the cornea. But we have done some other studies in the lab looking at the short-term effects of a sealed lens compared to a regular fenestrated lens, so not a gigantic central fenestration. Attempting, again, you come up against the difficulty of how do you measure the IOP. But in those pilot studies, which we have not published yet, there wasn't really a significant difference in pressure changes in the short term between a sealed lens and a single fenestration using the exact same lens design. But you know, all the caveats. It was a very short-term study, healthy eyes, yada yada yada. So I don't think anyone has answered that question yet, and we've tried in a very controlled laboratory setting, and the preliminary answer was there wasn't a lot of difference by adding a limbal fenestration.
I think one other thing to consider there is the fact that a number of studies, or most studies that have actually measured IOP with a device other than the transpalpebral tonometer, have found no change. So I would not expect a fenestrated lens to cause an elevation of intraocular pressure. If anything, it would decrease that. But if we're already not seeing elevation, it's going to be really tough to tell the difference between a fenestrated versus a non-fenestrated lens. I guess I wouldn't expect to see a difference there.
Makes sense. So I have a couple questions on conjunctival prolapse. One is, if the patient is doing well, is there a certain amount that is acceptable or too much that we're not okay with? And then secondly, if you do have prolapse that is adhering to the cornea, what do we do? That's a tough question.
I can actually address that a little bit clinically. I generally don't get too terribly concerned about it. I've never seen it cause any long-term problems. I did have one patient in whom I thought that conjunctival tissue was adhering to the cornea. She was actually hospitalized following a stroke, could not wear her scleral lens for a couple of weeks, and when she came back, the conjunctiva was no longer adhering to the cornea. So I may have said at a meeting at one point that eventually that conjunctival tissue could get sticky and adhere. I can no longer say that I've seen that happen. I suppose it could, but you've got the corneal epithelium, conjunctival epithelium. They're different tissues. Unless there's a major inflammatory process there, I wouldn't think that it would stick. But as long as it falls away immediately when you take the lens off, it's kind of ugly, but I wouldn't worry about it.
One other quick comment on that, and then I'll let Steve, is Muriel, you sort of showed the putting the lens on and pushing it hard. I've also seen that happen with the prolapse, where a patient will put their lens on a little harder and it sucks it up a little bit. So, you know, if I'm worried about it, I do educate the patient, like, put it on gently. You don't have to do this.
Yeah,
like,
be nice. One other thing that I have tried recently on the Boston Sight Facebook page, and I am not a paid consultant for Boston Sight at all, they mentioned putting fenestrations in the lens landing zone as a means of reducing the likelihood of conjunctival prolapse. I tried it in one patient and it worked. That is my N of 1. So Steve, maybe you could consider that for a future study.
Yeah, well, you could in your clinic as well.
Well, given the fact that I don't worry about it.
Well, yeah, just one other thing I've seen clinically, some people try is when nothing else is working, trying a piggyback approach, so a soft lens underneath the scleral to help with prolapse. And anecdotally, it's worked for some people, but that does introduce all the additional concerns around oxygen and handling two lens care systems and what have you, but that's an interesting idea.
And if you have the prolapse that's adhering, do you guys consider surgery, like if it's just sticking to the cornea even after you remove the lens, or just monitor, leave it be?
Well, like I said, I've never seen it actually stick. The idea that it may stick, I don't know, has anybody ever seen it stick?
No, and I had a patient actually recently who came to me, and she had a doctor say, we need to surgically remove this.
Yeah.
And she's an attorney. She's very smart. She was like, I don't know. And she came to us and we refit her. We went smaller. We went really low on the limbus, and it went away. So I've seen it go away, and I've not seen surgical intervention. I would highly, highly advise a patient against that.
That might be a little bit like trying to kill a fly on the wall with a sledgehammer.
Right.
I've actually gone a little bit bigger. So if you're getting conjunctival prolapse that pulls up over the cornea, let's just say that you're going to get 1.5 millimeters of prolapse no matter what you do. If I enlarge that corneal chamber by 1.5 millimeters, voila, that conjunctival tissue may still be bulgy a little bit, but it's not going to overlie the cornea.
Steve, did you see any different? Did you guys look at diameters and which had more prolapse? I've always gone a little bit smaller if I see it, just because I can get closer on the limbus, I think.
Yeah, no, in the studies we did with prolapse, we just modified elevation and kept the diameter the same.
Yeah. There's another study.
Another question about midday fogging. Have we seen if using Xiidra or Restasis or Cequa has any effect on midday fogging, or any of the findings under the scleral lens reservoir?
No. So the short answer is no. I thought a lot about these types of things, and I would say so. Not with those. So with those, right? So you're looking at something that's a T cell, like what, like Xiidra is anti-T cell locomotion. Cequa and Restasis are kind of anti T cell recruitment. So T cells are related to neutrophils, which is what we see, but we don't really see any T cells in the fluid reservoir. So, but that doesn't mean that T cells couldn't recruit these other cells. So I think probably, maybe it would help with some of the other inflammatory components that might be related to midday fogging, but it doesn't make perfect logical sense that it would work. I would say I have thought about other types of medications, ones that are more targeted towards like a neutrophil response, like a mast cell stabilizer, but I have yet to find any that are preservative free. But who knows? I might be doing a study with something like that.
The other thing to keep in mind is Maria found a fair number of wax esters. Oil can just make a mess of the front surface of the lens, and so really aggressive treatment of the any existing meibomian gland dysfunction is certainly to be recommended prior to initiation of scleral lens fitting.
Yeah. That actually leads to another midday fogging question. Someone said that they use a selenium sulfide shampoo, which I think is like a dandruff shampoo, I'm assuming, based on what they're saying here. And it actually has helped with their patients who can't keep their lens surface clean, even with BlephX or LipiFlow, things like that. It helps with, I guess, the scaly surface around the eyelids. And then what are your thoughts of using that off-label to prevent midday fogging?
So yeah, again, so the premise there being that if the lipids are the primary culprits and you treat the meibomian gland dysfunction, then you're going to have more normal lipids that wouldn't necessarily cause this. Again, like, there's the cells and there's the lipids, right? Because we saw a bunch of epithelial cells there. So I think it's logical. If somebody's got meibomian gland dysfunction, try it. If they've got midday fogging and it's making them crazy, try it. I mean, it's not going to be, I don't know about using this. I guess you're maybe talking about the eyelids. I mean, I'd be careful about toxicity. But if you kind of got a safe way. You know, I'm the type that will try it on myself. You know, I think try it on yourself, but I'm not giving you any real recommendations. But yeah, the science hasn't caught up to our, you know, where our minds go and thinking, oh, we'll try this, that, and the other. Sure, there's lots of different things that, you know, one patient has tried that will work, and maybe it works for some other patients, maybe it doesn't. So I think use your best, you know, clinical judgment. And if you think it's something that's safe and they try it, then definitely let me know, because, you know, it's this anecdotal stuff that leads to us designing studies to actually look more formally. So be excited to hear anything. I'm going to look that one up too. This is recorded, so I'll look back at this tomorrow. Selenium sulfide or whatever.
Yeah.
Okay.
Awesome. Thank you participants for all the questions, and speakers for answering all of those during this time. I really appreciate you guys taking your time out on your Wednesday night and going through all this with us. We're going to go ahead and wrap up for tonight. And then for all the participants, just as a reminder, we do have a brief survey as soon as the webinar ends. And we also look forward to seeing y'all at IFSLR in January, either virtually or in person. And hope you guys have a great evening.